Welcome to today's ECHO presentation. My name is Amanda Tavalda and I will be your moderator today. Today's presentation is No Right Place to Die, a palliative approach to serious mental illness. And to begin, I'm going to do a land acknowledgement. As visitors on this land, we have a responsibility to acknowledge the grounds on which we are privileged to live and to honor the Indigenous peoples who are the original stewards of Turtle Island. Here in Aurelia, which is where I'm located today, we are on the traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council, Beausoleil, Rama, and Georgina Island, and more recently the Mississaugas of the Credit River First Nation. As a mother, I'm grateful that my family can enjoy the beauty of this land. That includes hiking, camping, playing. These are all simple joys made possible because of the Indigenous peoples who have cared for this land. Land acknowledgements are only one step, but they're part of my ongoing commitment to learn with my children about the history, the realities, and the resilience of Indigenous peoples, both past and present. The end result can only be a better and brighter future for everyone who calls this land home. I encourage you all to do the same. And so I've already mentioned today we're here for the Palliative Care ECHO project. This began as a 5-year initiative. We're past the 5 years, so we're very excited to be continuing on. And we would like to thank Health Canada for their financial contribution to the project. And so today we are joined by two wonderful people who are going to have a great presentation. You'll have lots of great information presented by Julie, who is with the North Simcoe Muskoka Hospice Palliative Care Network. She is one of our palliative pain and symptom management consultants. And then we have Chantal, who is the clinical educator with Waypoint Center for Mental Health Care. Ladies, the floor is all yours.
Thanks, Amanda.
Thank you.
There is a QR code there that you can screenshot, or Amanda will be sending out an email following today's session. We love feedback, so please send us your feedback on this presentation today. So our learning objectives, we are hoping everyone will be able to understand the unique challenges and disparities in providing palliative and end-of-life care to individuals living with serious mental illness, understand the principles and practices of a palliative approach within psychiatric settings, including symptom management, multidisciplinary collaboration, and ethical considerations. And finally, to apply practical strategies and resources to improve quality of life, support decision-making, and enhance person-centered care for individuals with SMI at the end of life.
Yeah, so to get started today, we just want to take the opportunity to identify some terms and abbreviations that may be unfamiliar to you and your current practice. So you've already heard one, which is SMI. It's also known as serious mental illness. We use SPMI a lot in this presentation, so serious and persistent mental illness. The Government of Canada defines SPMI as changes in an individual's thinking, mood, or behavior, and is usually associated with significant distress or impaired functioning in social, occupational, or other activities. Next slide there, Julie.
Thank you. So, as a basic introduction to the palliative care is an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification, impeccable assessments, and treatments of pain and other problems, physical, psychosocial, and spiritual. And that's the World Health Organization. So in addition, a palliative approach to care should be initiated upon diagnosis of a life-limiting disease. And then the other part of the spectrum is end-of-life care. So that is designed for people in their last months and weeks, focusing on comfort and support as death approaches. So this was a term I really was not familiar with until I really started working with Chantal at Waypoint, supporting their facility with palliative symptom management. So beneficiaries of palliative psychiatry are patients with severe persistent mental illness who are at risk of therapeutic neglect and or overly aggressive care within current paradigms. These include long-term residential care patients with severe chronic schizophrenia and insufficient quality of life, those with therapy refractory depressions and repeated suicide attempts, and those with severe long-standing therapy refractory like anorexia nervosa. It is an innovative approach to caring for persons with SPMI is required when the chances of achieving clinical recovery are unacceptably low in relation to the burdens that treatment poses for the patient. It addresses the associated ethical challenges by prioritizing quality of life and relief of suffering and over clinical recovery, sometimes even over survival. And Chantal's going to give us a brief little example.
Yeah, so part of my job at Waypoint is I support our specialized geriatric services. So within those services, we have folks that have dementia most commonly, and sometimes in addition to dementia, another mental illness, whether that be anxiety, depression, schizophrenia. So within this program, we're really starting to use this palliative approach to psychiatry in select patients. So most recently, we had a patient in, she had severe anxiety disorder in addition to ADHD. And this really impacted her quality of life. She was at the point where she wasn't able to complete her ADLs. She wouldn't leave her home. She wouldn't interact with others, even her family. So when she arrived at our facility, the realistic goal for this patient was to optimize their quality of life and not necessarily to treat the illness. We did see success with this method because as on discharge, she was interacting with other people, she gained more independence with their care, and she was leaving her room and communicating with her family. Definitely not every day, but more than she was, and she was able to gain a quality of life that she didn't previously have. Next slide, please. Yeah, so as I said, I am from Waypoint. For those of you that don't know, Waypoint is a 315-bed academic and teaching hospital that serves folks with serious mental health illness. We are one of the largest forensic mental health hospitals in Canada. There's only actually two of us. It's us at Waypoint in Ontario, and there's one out in BC. We have various specialized programs for our patients. We have over 1,500 staff. We have 800 outpatients. We are quite a large facility, and we are recognized internationally for leadership and research. Next slide, please, Julie. So like I said, we do a little bit of specialized care. So some of our highlights are the Horizon program for geriatric care, which is one of the units that I support. We have specialized voluntary addiction programs. We also support dual diagnosis, ECT and RTMS treatments, which is fairly new for our region, and the forensic programs. The photos that you see on the slide are from our forensic programs. Next slide there, Julie. Thank you. So even though Waypoint is considered a hospital, it's not an acute medical hospital. That being said, we provide good care, but we provide very specialized care for folks with severe mental illness. So those patients who have a care plan involving, full resuscitation generally will be sent to the local hospital for ongoing acute care. Some barriers that we do meet is some resistance from ORB, so the Ontario Review Board, and we'll talk about that in a little bit, PG&T, so Public Guardian and Trustee, and having patient statuses change to end of life and obtain DNR orders. We always find a little bit of barrier with that. It can take a substantial amount of time in order to do this, just because the Healthcare Consent Act defaults to the highest level of care. And if folks are with PG&T, the highest level of care is oftentimes not a DNR or not to pursue end-of-life treatments. Even if a person is admitted involuntarily to that psych facility, they can't be treated without the consent or the consent of the substitute decision maker. We also have some issues with medical assistance in dying as a limitation. MAID is not provided at Waypoint. Waypoint is a Catholic facility, and therefore it doesn't align with the values. We are working on it at the moment. That being said, patients have the right to access information about MAID and have the access to have it facilitated if they so wish. If a patient does have SMI, but also a physical terminal illness, they may be approved, and we've had patients that have been approved, and they are always welcome to have information and around it. And also we have limitations around transfers to other facilities. We have done transfers in the past to other hospitals, hospice, long-term care, group homes, or independent residences, so their own homes for end of life, but it's becoming more infrequently the case. Our patients, some of them that have the ORB that needs to agree, so those are our high secure forensic patients. It takes sometimes years in order to move them to a different facility, so it may not come in time. And we are often told that because they're technically at a hospital, they do have access to 24/7 nursing care, so then are declined for other services, even if being at the psychiatric facility is not the best place for them to be at that point in their life. So for us, the primary reason a person is admitted to our psychiatric facility is to regain stabilization, diagnose new illness, arrange appropriate community supports, and house those patients who are in the justice system who cannot go to prison. Physical illnesses often go hand in hand with psychiatric disorders and will require specific support to manage those conditions as well. This is especially true the older our patients are. We're going to discuss a bit of that overlap of physical health conditions.
So what percentage of Canadians do you believe have both a significant mental illness and a physical comorbidity? You can just put your answers in the chat there.
I'm seeing 30%, 20%, 10.
Well, you're all very close. It is 20%. So kind of a 1 in 5 that do both have mental illness and a physical comorbidity. So there's so many contributing factors related to those comorbidities with increased mortality. In addition to physical chronic illnesses, a person with SMI may also have other psychiatric illnesses. So for example, different types of anxiety, panic, depression, dementia, and delirium may coexist with their primary psychiatric illness. There's higher risk of poor prognosis, increased hospitalizations and then readmissions, worsening quality of life, worsening of their mental health, and hospitalizations for SMI itself, increased ER visits and longer stays in the ER. Now, this may be related to concurrent or previous substance use, homelessness, lack of family physician, lack of transportation to healthcare facilities, and many more. Sometimes poor medication adherence or compliance, polypharmacy, inappropriate prescribing, lack of continuity of care, and patient and family satisfaction can all play into this as well. For example, those with schizophrenia had more physical health conditions, a greater all-cause mortality, and poor physical health and treatment outcomes. People with SMI are 2 times more likely to also have a substance use disorder, and 20% of people with SMI have a co-occurring substance use disorder. Now, with those with schizophrenia, this could even be up to as high as 50%. So an example is to consider how complex the lives are of these folks, especially if we look at the determinants of health and the intersectionality that is present in this population. So for instance, we know that there's a high correlation between schizophrenia diagnosis and diagnoses of other chronic conditions like diabetes. So say, for example, that we have an individual with a diagnosis of schizophrenia and diabetes. We know medication for both of these disorders is very expensive. And we also know that both of these disorders can have really large functional impacts for individuals. What if this person's symptoms of schizophrenia become unmanaged? What happens to their income and subsequently their expenses, their social supports, their housing? How do other people interact with them in the community? What about their management of their diabetes, their nutrition, their follow-up care with community healthcare providers? How are they purchasing their medication? Also, in summary, for chronic disease, there is a lack of research into the physical comorbidities and SMI and their combined effects on the person themselves. So first, we're just going to break down some of the categories of SMI. So mood disorders. About 4,000 Canadians die by suicide every year. This SMI primarily affects the person's mood. So whether it's persistent and intense sadness, elation and or anger, depression, so whether it's major or clinical, bipolar, also used to be called manic depressive, mood changes that are normal, but persistent symptoms beyond several weeks is not, change of behavior and affect abilities to perform routine activities, so work, home life and school, also affects eating, sleeping, thinking abilities, so racing thoughts, energy levels, increased thoughts of suicide and risk-taking behaviors. It can affect anyone of any age. Major depression affects more women and is often linked to chronic diseases such as heart disease, diabetes, and Parkinson's. It is treatable with medications, therapies, ECT, and RTMS.
Yeah, we're gonna move over to psychotic disorders. So psychosis in itself is not necessarily a diagnosis, but it's more of a cluster of symptoms. And it can manifest in many ways, and it's really quite individualized, meaning a psychosis or psychotic symptoms will look very different from one person to the next. There's other conditions that also increase the risk of going into a psychosis, such as bipolar disorder, major depressive disorder, communication disorders, OCD, PTSD, and body dysmorphic conditions. So essentially, this is a mental state resulting from a loss of contact with reality. So they have a hard time distinguishing, what is real or what is not. There's disruptions to thoughts and perceptions with hallucinations, delusions, incoherent behaviors, and speech, lack of emotion, and some even stop speaking altogether. And again, it doesn't mean they have to experience every one of these symptoms. And again, every person is entirely unique. So some of the disorders that we see at Waypoint, we have folks that have schizophrenia, delusional disorders, we have a substance-induced psychotic disorders, schizoaffective disorders, and schizophreniform disorders. There's also some of these psychotic disorders that relate to medical conditions. So folks that have severe strokes or brain tumors or brain injury, delirium, Alzheimer's disease, or Parkinson's disease can be affected as well. And typically we treat with antipsychotics, counseling, social supports, and we really try to keep an eye on the risk of self-harm and suicide in this population. Thank you. So personality disorders, think of it kind of like a rubber band. When we are growing up, we learn how to flex and bend like the rubber band. People with personality disorders do not have this ability, and it's not their fault. The rubber band is frozen, and when you stretch it, when something new comes along, it will snap. It's an inflexible and unhealthy pattern of behavior and thinking over long periods of time. And these deviate from the expectations of culture. So it's really important to understand where your person is coming from and what their background is, because what might feel normal to you in your culture is abnormal to them and vice versa. And it's really important to note that as Canadians and around the world, we provide care to folks of many different backgrounds. And how one culture defines appropriate, like I said, may be completely different. It only becomes a problem if they're maladaptive. So maladaptive behaviors are things like substance misuse in relation to unhealthy coping, impulsivity, poor quality of life, difficulty relating to others. And we do see quite a few of these personality disorders. For the most part, we do see paranoid personality disorders, schizotypal personality disorders, narcissistic, antisocial personality disorders, which used to be called psychopathy, and borderline personality disorders. Typically, we treat these with medications, so antidepressants, mood stabilizers, antipsychotics, anti-anxieties. We do a dialectical behavior therapy, or DBT, CBT, and psychotherapy. And this is a long road to walk. This is lifelong patterns of seeing themselves and reacting to others in ways that cause problems and hard time understanding emotions and tolerating distress. And again, it is no one's fault. I will say as a caveat here, folks that have borderline personality disorders, at least in Ontario, as a diagnosis, it actually excludes those folks from many services designed to help them in any part of their journey, and especially at end of life. Next slide, please, Julie.
So a lot of people are familiar with dementia and delirium, and yes, it is a serious mental illness. Dementia affects approximately 8.7% of Canadian adults over the age of 65. But we are starting to see dementia earlier in their 40s and 50s and 60s. But these are stats from 65 and older. It's not a normal part of aging, even though a significant amount of people do suffer from this. And basically, dementia is marked by progressive decline in cognitive function that may affect their memory, their thinking, reasoning to certain degrees that impacts their daily life. There are many types of dementia, including Alzheimer's, vascular, Lewy body, frontotemporal, CJD. They're all different types. And for the purposes of this presentation, as it pertains to our case study, I will also mention Korsakoff dementia. Korsakoff dementia is caused by severe thiamine deficiency that is typically associated with chronic alcohol misuse. When providing care for this population, it's important to note that identifying pain becomes increasingly difficult. So we need to learn to recognize those nonverbal signs of pain. It becomes a vital part of our everyday assessments. Delirium, on the other hand, is an acute change from baseline that may present as increased confusion, difficulty thinking or remembering, and drowsiness. It's a spectrum. You can be hypodelirious, where they are sleeping 23 out of 24 hours, or hyper, where they're wandering, they're pacing, and can become violent. Delirium can be expected at the end of life and is especially prevalent in individuals who have dementia, but we also see it in young people with cancer and, other types of life-limiting illnesses. So in the setting in which we're seeing these patients, ideally we're identifying the cause. So, it's like a detective job as well. Was it a new medication? Was it a change in their environment? Do they have an active infection? Is there an exacerbation of their underlying other chronic disease illnesses? And providing treatments to reverse that delirium. However, at the end of life, reversing that delirium is unlikely, and instead the focus is the comfort of the patient. So dual diagnoses. So this term is specific to Canada. In the US, they do call it something else. And Chantal, for the life of me, I cannot remember what it's called.
Concurrent disorders.
That's it, concurrent disorder. So in Canada, we call it dual diagnoses. And it is basically a person with a developmental disability is also higher risk for developing a psychotic disorder. So this is where the dual diagnoses, their developmental or intellectual disability plus a psychotic disorder. So it's 3 to 6 times more risk for developing this psychotic disorder. Between 10 and 30% of Canadians are thought to have a developmental disability. And that is, that big umbrella term when somebody has significant limitations in cognitive functioning and adaptive function. So, for example, Down syndrome, congenital rubella, fetal alcohol syndrome, and autism spectrum disorder.
So just like the general public, healthcare professionals are not immune to having personal biases related to, our experiences and, perhaps lack of education regarding those patients with a SMI. It occurs in all settings with different types of individuals with unique challenges related to their health. Some examples of bias in healthcare providers include, perhaps you're an ER staff receiving a patient from long-term care with behaviors, or any type of patient from my facility at Waypoint discharge back, and we see that they discharge back to our facility before it may be appropriate. So some examples would be, people with mental illness are inherently dangerous. Specifically when speaking to schizophrenia, in fact, patients who have a significant mental illness are far more likely to be victims of violence than perpetrators of it. There is difficulty in accessing care. Like I said, borderline personality disorder, for instance, those folks, once they have this diagnosis, are automatically disqualified from a lot of services that would be helpful to them, particularly true in Ontario. There's also misdiagnoses based on social norms. If a person is in a different culture and are reacting to a stressful stimuli that is culturally appropriate for them, but not culturally appropriate here or with whatever provider, they might be diagnosed with a mental illness or provided with labels. Some pain assessment tools aren't designed for those with someone with SMI, not only if they're cognitively impaired, but those with illnesses that alter perception or alter their own reality. There's mistrust in the healthcare system and its providers. I will say people that I support at Waypoint are often fearful of the healthcare system. Too often they are hauled in, they're labeled, they're provided Band-Aid treatments, and then really discarded with few supports in the community. Unfortunately, the current structure of the system, again, I'll speak specifically to Ontario, is to prioritize access to treatment only when people are deemed disruptive or unstable or difficult to manage. There's fear engaging with the system. This is why it is so important for us as healthcare providers, as members of our community, to remember that people we provide care to who have a mental illness have likely directly experienced the structural violence and stigma that is inherent in our healthcare system. It's really important to be mindful of any personal biases you may have and avoid stigmatizing language whenever possible. You'll notice in this presentation, I say a person with the mental illness and not a schizophrenic, for instance. So why should you care? How is this applicable? Now that you have some of that background context, it really brings us to the heart of this presentation. For almost the last decade, there's been this discourse in the research community around the idea that folks who have mental illnesses or mental health concerns have no right place to die. If you were to search in any academic database right now with the keywords palliative and mental illness, most of the articles that will be available will talk about this. There's this pervasive and underlying idea that for vulnerably housed folks, shelters aren't an appropriate place to die. Those who have a mental health diagnosis but try to attend an inpatient mental health organization for end-of-life care only, no exacerbation in their mental health illness, are turned away. If they then approach a general hospital for end-of-life care, they're often also turned away because of their mental health diagnoses. And while referrals to hospice can be placed, they are often declined or challenged due to presentation or fear of symptom management. For those seniors living in long-term care with dementia and other SMI, that environment may not be inclusive to optimal care due to lots of variables, including lack of staff resources, insufficient education and training, inexperienced staff, the workload to the providers, and the scarcity of locked units for wandering residents. In general hospitals, often individuals with SMI are physically and chemically restrained, again, in Ontario. They might have police involvement and have similar deficits in environmental control and perhaps minimal staff education. It's really important that we understand who's receiving the care we are providing, recognizing the barriers that those people may have faced and that you may run into in your practice. It helps provide the foundation for developing a person-centered plan of care to support these folks at the end of their life. Next slide, please, Julie.
Thanks, Chantal. So let's talk about providing palliative care. It's definitely a multidisciplinary approach. An explicitly palliative approach within psychiatry has the potential to improve quality of care, person-centeredness, outcomes, and autonomy for patients with severe and persistent mental illness. So just like anybody else, we need to look at advanced care planning, goals of care, and wishes conversations. We need to also ensure that psychiatric and physical illness symptom management are co-concurrent, that we're also doing appropriate referrals for OT, PT, social worker, chaplains, myself as a palliative pain and symptom management consultant, palliative care physicians, and other specialists. And we can't forget family and the support and the involvement that they can offer the care team and for their loved one. An interdisciplinary approach creates more opportunities for individuals with SPMI to access care and broadens the resources available both to the patients and providers. So some of the physical symptoms that, we're going to see literally in everybody who has a life-limiting condition. And remember, we did mention that people with SMI have a higher risk of comorbidities. So a significant number of individuals suffering from SMI will also experience physical conditions, including cancer and chronic diseases. Symptom management at the end of life is very similar in principle, but may not always be available depending on the type of facility they are in, just like Chantal had mentioned previously. Waypoint is unique in regards to particular restrictions related to safety, governance, and the limited medical equipment and specialty they can provide versus a general acute hospital or hospice. Long-term care homes are similar to hospice organizations as they will do their own palliative and end-of-life care. After all, this is the resident's home. The ultimate goal of any organization providing end-of-life care is comfort, whether through the use of medications, non-pharmacological interventions, grief counseling, friendly visiting, providing a home-like environment, and psychological management. All the domains of care should be utilized. Palliative care is holistic. It's not just about controlling pain and other symptoms. Variable symptom management is available at most facilities, including access to intermittent sedation, medical assistance in dying, use of medications, and palliative sedation. Using validated symptom assessment tools like ESAS, OPQ or STUV, McGill Pain Questionnaire, depression tools, etc., may not be the most appropriate tool to use in those with SMI. Tools used with cognitively impaired adults like PainAD, Wong-Baker Faces, and the FLAC tool may be more suitable, but doesn't elicit factors like emotional pain, psychological distress, and existential suffering, as we would see in the total pain concept. Remember that assessment tools are only one part of symptom assessment. Using observable behaviors, signs and symptoms of subjective data, if we can get that, or other tools in your tool belt. Getting family and caregiver input is important as they may know what nonverbal cues mean to that person. Medication reviews are important when starting to add pain medications, sedation, anti-nausea meds, especially due to the high risk of side effects and adverse events when taking with strong antipsychotics. As you'll see in the next slide, we will briefly discuss psychiatric medications commonly used and those with SMI, but their commonality in the use at the end of life.
Thank you, Julie. So yeah, psychiatric medications, like most medications, or not most medications, but significant medications, several of these need to be weaned before discontinuing, which isn't always possible if, death is rapidly approaching. So in terms of these types of medications, we consider the use of sedation in place of the psychiatric meds if the behaviors are prominent, and we try to manage those side effects. So we use a combo of other meds and weaning if we can. We try to use psychiatric meds only for symptom control if we're able to. So things that you would already use in end of life care. I will have a quick important note around antipsychotics. They are one of the top 20 meds in general that are prescribed to hospice patients. These include, Haldol, Nazanan, Ativans, olanzapines. But there's not really much evidence currently to guide psychiatrists and other healthcare providers on the use and discontinued use of the psychiatric meds at the end of life. In the research, I think this was from the British Medical Journal, psychiatrists were more likely to wean and stop psychiatrists were more likely to wean and stop antidepressants and mood stabilizers, while palliative doctors were more often deciding to switch from a oral to an injectable antipsychotic. And like most, if not all, mental health organizations, Waypoint utilize medications that do include these antipsychotics, mood stabilizers, and opioid agonist therapies to support treatment of symptoms for our patients. These medications are necessary for some of our patients to have an increased quality of life. And we know that when people transition into end of life, swallowing reflexes change, as well as their interest in eating or drinking. And this may progress until they are unable to swallow entirely. So normally oral medications are stopped. If a palliative approach is started late into the dying process, it's likely that the patient will experience withdrawal symptoms, as medications cannot be titrated off effectively. And this may cause distress to the patient, to their personal support network, and to us, right, as healthcare providers. This can be true of any person, not just for people who have a mental illness. I will point out one medication in particular. It is clozapine. This medication is normally provided to patients with treatment-resistant schizophrenia. That's what we use it the most for. And it really tends to be used as a last resort, given the considerable risks associated with adverse effects and the intensive monitoring this medication requires. If there's a patient on clozapine that is end of life, the person can experience, cholinergic symptoms, so nausea, vomiting, delirium, as well as potentially catatonia, serotonergic symptoms, withdrawal-associated psychosis, delusions, hallucinations, or a thought disorder. And 1 in 5 patients that are taking clozapine will experience a sudden emergence of psychotic symptoms if clozapine is abruptly discontinued. So we call it a rebound psychosis. These patients are, really particularly vulnerable to symptom deterioration once, this withdrawal psychosis, rebound psychosis has resolved. While providing end-of-life care to these patients, it is really important to recognize the signs and symptoms of withdrawal from these medications. Establishing palliative supports early on and specifically planning to address the medication management well in advance can help support these patients in titrating off medications that are only available in oral doses. Clozapine currently in Ontario does not come as an injectable, and we give it either as a pill or as a liquid orally. Another considerations as these medications are discontinued is other means to manage the symptoms that may be distressing to the patient. So this can include other pharmacological interventions, like we mentioned with, Haldols, lorazepams, olanzapines, and so forth, but also increased engagement from allied health teams if you have that available to you in areas such as, recreation therapy, psychotherapy to support symptom management, or alterations to the level of symptom acceptability. And what I mean by that is, as Disturbing or disruptive, somebody that is undergoing a withdrawal psychosis or a rebound psychosis when they're getting off of certain anti-psych medications, it's not for us to decide what is distressing to that person. If the patient is managing well with their kind of new level of symptoms, then that's the level that we're trying to aim for. We're not trying to aim for the absence of symptoms. And it's important as well to include that patient in that discussion. It just because they're deemed palliative or end of life, it doesn't mean they no longer, find their own symptoms distressing, but it's just finding that level that they are okay with in that moment. Again, early conversations about symptom tolerability and preferred supports is crucial in this population. Next slide, please, Julie.
Great. Thanks, Chantal. I know a lot of people have difficulty with the medication piece of the care. Okay, so breaking through barriers. So, you know what? There's tons of barriers. There's tons of stigmas and bias just in mental health in general. There's some difficulties being understood by healthcare providers. There's lack of social support from family and friends, that who are affected by poverty and homelessness and substance abuse, among other social and health disparities. Some of the challenges in providing care to those with SMI include communication between patient and provider, difficulties managing the symptoms of SMI, complex comorbidities associated with the SMI, and hugely, the patient mistrust in the medical system. Patients residents with SMI must have the same access to excellent palliative and end-of-life care as anyone else without an SMI. Unfortunately, we are not there yet, but by advocating for our patients, furthering our own education about SMI and palliative care, working with our local, provincial, and federal level organizations, we can certainly help our patients achieve optimal care that they need and deserve. Next, for just a quick note about end of life and forensics. There's a lot of opportunities that Waypoint on their forensic units are doing end of life care because there is no other place to send them to. Like Chantal has mentioned, the lack of hospice availability, going to an acute medical hospital may not be the best thing. And some patients want to die at Waypoint. So some of the barriers to providing end-of-life care in forensics is the Ontario Review Board, their disposition. Can we get them out? Who will take them? Can we get them community supports so they could die at home? Substitute decision makers versus PG&T, contraband, complications related to severe mental illness, and as Chantal mentioned earlier, the disparities of being able to access MAID. And in addition to that, MAID for the sole purposes of severe mental illness has not been approved until 2027. This highlights the importance of early recognition and having these discussions related to advanced care planning. By having these discussions and creating a plan helps both the patient and the staff be prepared in the event that the facility is providing a palliative approach to care or end-of-life care. Not waiting until there's a crisis or the patient requires the care in the moment, but have to go through that cumbersome process of the Ontario Review Board and or SDMs or PG&T will often come to decisions past the time needed or within days of death. And Chantal, when she talks about the case study, we'll go through that. Being creative within our limits, speak to understanding what we can provide in the context of secure forensics. Many items that you would consider commonplace in your practice, like lamps, pain pumps, certain beds, oxygen tanks, are considered contraband or high-risk items. In addition, the rooms are too small to operate lifts. And I got to see some of this. And yes, it's definitely a different world in palliative care, trying to do it on the forensic level. So, example, talking about an appropriate bed, staff have to fill out 3 requests to get the original bed unbolted from the ground, then remove, then receive another bed. It takes time. It requires 3 different departments to complete this simple transaction. Like I said, historically, Waypoint hasn't provided much end-of-life care, but they are doing more and more of it as time goes on. They have a unit aging in place, and they are receiving folks with more comorbid illnesses, and providing this care will become an expectation. And in order to provide that high quality of care, ensuring resources are readily accessible for staff will ensure this care can continue. So before we get to our case study, in our practice, psychiatry is the fastest growing field in healthcare. It will come as no surprise that the only thing we know for sure is that we don't know enough. The body of research outlines a very real gap of knowledge with healthcare provision for individuals experiencing SMI, especially when it comes to palliative care. Severe mental illness and physical concerns often walk hand in hand. People with SMI are more likely to die at a younger age, 10 to 20 years earlier than the national average. Over half the people with SMI also have significant physical illness like diabetes, COPD, and peripheral artery disease. We appreciate that providing a palliative approach and end-of-life care to this population can feel challenging, given those differences that we've mentioned throughout our presentation. Our goal here is to provide some pointers on how to provide care to this population and provide some avenues for continuing your learning when this class is over. So, number one, using an open, non-judgmental approach with a person-centered and person-led approach is an invaluable tactic. So, for example, through this presentation, we've been putting the person first. We use terms like a person with mental illness, a person with schizophrenia. The use of terms like schizophrenic or narcissist are outdated, antiquated, and hurtful. So please, try not to use them. Validate the experiences. Ask the person what care they are looking for and allow time for them to ask questions. Despite an increased risk of poor health outcomes for this population, people with these diagnoses have limited opportunities to engage in advanced care plan discussions, often being spoken over or about. Common assumptions that misinformation, the provision of care includes that these people have impaired capacity to make treatment decisions or to communicate wishes, and that the person is unlikely to engage in planning or conversation around palliative or end-of-life care will actually destabilize them. In available literature, which is little, spanning over 2 decades, individuals with SMI identify that being involved in their care, having their voices heard, and using their values and wishes is helpful to them and should be the foundation of a palliative approach. Yes, some people may need a little more time to process information and ask questions, but it certainly doesn't negate their expert status on their own lived experience. 3, pay attention to the symptoms a person exhibits. As mentioned earlier, people with SMI who discontinue antipsychotic medications abruptly may experience that rebound psychosis that Chantal has talked about. This can be one of the more distressing conditions for a person to experience, as well as distressing for their family and the care providers to witness. The symptoms of rebound psychosis can be confused with regular symptoms of that person's illness. For example, a person with schizophrenia may have delusions or hallucinations at their baseline. Generally, these symptoms do not change in theme, but you might see them become more intense or fluctuate. This fluctuation or differentiation from baseline is an indication that there is a need not being met and could be due to withdrawal from medications. This is your opportunity to provide supportive interventions, whether pharmacological or not, and should serve as a notification to you that there are unmet needs which are likely causing distress to the patient. Remember, symptoms are often signals. Lastly, regular symptoms that we associate with palliative status, as outlined in the ESAS, can look entirely different in someone with acute mental illness or an exacerbation. The number one symptom that presents differently is pain. People with schizophrenia have a high pain threshold, for example. Other difficulties in assessing pain in this population may include lower effectiveness of articulating what pain is or completing a fulsome pain assessment. Unfortunately, physical symptoms that are reported by this population are often ignored, disbelieved, or attributed to their mental illness. The best advice we could offer is if there is a symptom reported, explore it. Spending time with people and developing a therapeutic relationship will allow you to understand and know their cues to provide effective symptom management. So now we get into our case study
You tell him Lord of the Rings fan. So this is Mr. Baggins. He has a lot of stuff going on. Physically, he is very unwell, cirrhosis, epilepsy, cholelithiasis, recurrent UTIs, you name it, he kind of has it. And in addition to that, he has, or had rather, schizophrenia, major neurocognitive disorder, which is our Korsakoff's dementia, cannabis use disorder, and nicotine use disorder. So as you can see, a lot going on. From his background, he didn't have any family that was going to be his substitute decision maker, and he was deemed incapable of making certain treatment decisions. So he was with PG&T. At the time he was admitted to us, he was a transfer to hospital, no CPR. He was married, he's divorced with children, he had a post-secondary education, he was retired. And really our goal of this admission was to do the medication review, address the new addiction issues, enhance his community support, and ultimately discharge him. Next slide, please, Julie. We did a lot of investigations. We have something called the Waypoint panel. So on admission, this is fairly common for most folks to have, with the exception of the FIT test and the liver function test. That was specific to him. Ongoing, we were always making sure we were doing blood work, we're checking out his urine. And when he was transferred over to our specialized geriatric unit, we did something more in depth. We did, sleep clinic studies. Chiropody was seeing him, kidney functions, bladder scans, x-rays, MRIs, and biopsy of a lung nodule, which did turn out to be cancerous. Next slide, please, Julie. So there was a lot of barriers to care for this man. He did request MAID at 2 occasions, and it was denied both times due to his cognitive status at the time. There was increase in his expressions of risk. So this is what you might have heard be called, violent or anything kind of like that. So, grabbing at the catheter, putting himself on the floor, like those kinds of things. He was extremely medically complex for our facility, and he experienced a very sharp decline, like matter of months, going from walking to wheelchair, full sentences, reading books to not doing that anymore. And he also experienced rebound psychosis. Next slide, please, Julie. So we did the best we could with what we had at the time. So we did an ethics consult simply because, if he did remove the catheter, we would have to put it back in, but he was very difficult to catheterize and did not like it, as well as kind of any other thing we wanted to try to do. We wanted to make sure ethics kind of cleared it. We made sure we had recreation referrals. We found he really enjoyed certain activities, and we really wanted to increase his quality of life. So we found opportunities for him to participate in swimming, like supportive swimming, or outside, or anything that was kind of going on, make sure he still felt very involved. We had occupational and physiotherapy down on the units, making sure that we were using the lift that was the most safe, had the chair that made the most sense for him, really increased his quality of life in that way. And we do have the benefit of having behavior support specialist. So she really helped to identify any kind of precursors to any sort of quote unquote behaviors, which were really just him trying to get across that there were some unmet needs that needed to be addressed. So at the end of life, not only did he ask for MAID twice, but we also referred him to hospice twice, and he was declined both times. Again, declined because technically he did have access to 24/7 nursing care, and we have a very tiny hospice where we are, and he only wanted to go to one place. We tried to do medication titration, but we weren't able to. He was on clozapine, and he did have rebound psychosis. We got him into a private room. We changed his catheter to only for comfort. So if we couldn't get it back in, we would do a bladder scan and then try again maybe later, but really for comfort for him at that point. And he was using the Pinel restraint system at certain points during his care. So we tried to minimize, if not completely eliminate the use of them. And another big barrier was the goals of care was actually only changed 4 days before his death, when he was showing a decline over a matter of weeks and months. Next slide, please, Julie. So this really led to a lot of care improvement. So there's lots of education that needs to occur, inclusive of no medications, rebound psychosis, expected findings at end of life, and the partnership with Julie and her team has really been helpful in that. Adequate pain control. There was no pain medication ordered for Mr. Baggins at his end of life at the time that he did pass away. So again, with our partnership, we developed full order sets that include pain management. We needed a standardized approach. There were so many providers involved in his care. I think at one point it was like 6. We really needed to develop a baseline standardized process, which again, in partnership with the network here, we did develop the order sets, which have been used I think 26 times now since we put it in less than a year. And the staff support, they were very distraught over his death. He was well known to many staff through the years. So Waypoint has been working on being able to have folks actually come and support them and talk to them when we have patient deaths for people that we've known. I knew Mr. Baggins myself for 10 years, give or take, before he did pass away, and some staff knew him longer. Next slide. So I've just breezed the case study in the interest of time for all of us. But we also recognize that mental health care, like palliative care, is a specialty. A 1 hour talk will not and absolutely cannot cover the depth and breadth of knowledge required to feel confident in providing care to this population. And that's okay. To assist, we recommend the following resources to you. These are resources that we also recommend to our new hires at Waypoint. I have done a few of them. I've done the EQUIP and the CMHA recovery colleges. They are fantastic. I will recommend also, the American Psychological Association has an inclusive language guideline that you guys can take a look at. But all of these courses are free. They're great resources, and it really helps you to become more curious about this population and perhaps, further your education so we can provide better care. Next slide, Julie.
So in conclusion, Chantal and I'd like to encourage all of you here today to continue educating yourself and your team members on that importance of incorporating serious mental illness education within your organization. In addition, a call to action, we're hopeful for new research into a palliative approach to care related to serious mental illness and improved implementation of policies to enhance your palliative and end-of-life care programs. So this is our contact information. Feel free to screenshot it, but you'll also get a copy of the PowerPoints as well. And then something to think about as you carry on with the rest of your day is, what will you take forward from today's presentation to incorporate into your own practice? And we have multiple pages of resources that you'll get in the package. And lastly, please remember to do the evaluation. So I am going to stop sharing.
That was great. Thank you so much, ladies. There are a couple of questions in the chat if we have a few moments. May not be an issue with Waypoint, but this person finds that as someone with SMI, they have trouble getting physical illness to be acknowledged or treated once that
Absolutely.
medical professional sees the medication list or diagnosis. Do you have any recommendations around this?
I have a not PC one. I often, because we do see this with our patient population as well, thankfully, when they do arrive at Waypoint, they have both a psychiatrist and a medical practitioner that sees them. But when they're in the community, something that our patients have said have been helpful is to asking their at-home provider to indicate on the chart that they're refusing to listen to their symptoms and provide the rationale why, which is not a very PC answer, but that is the one that's been working for some of our inpatients.
Perfect. Thank you.
Yeah, self-advocating that, their serious mental illness is just as important as their physical illness. It is both are
Absolutely.
affecting their quality of life. So unfortunately, yeah, you have to self-advocate for yourself a lot of the time, or advocate for your family member if they can't.
Yeah.
And then another question from this person is that they are an intake coordinator for residential hospice. ESAS will often show depression and/or anxiety, especially with cancer patients, but doesn't differentiate from SMI, which as consumer feels important, though also worrying about putting SMI in the list of diagnosis due to biases that people hold.
Exactly. And if people aren't truthful when they are giving us their medical history, it's hard to accurately treat them and provide that optimal care. So there's a lot of work that needs to be done, but just advocating for yourself or your person or your patients is very important. And when it comes to symptom management from the symptom assessment of the ESAS, that's why if they're cognitively intact and can answer questions, going into the OPQ or STUV algorithm will help address, okay, is this depression from their, maybe they do have an SMI of depression, their chronic lifelong depression, or is this related to a new diagnosis of cancer, or now they have to do even more chemotherapy, or, it's spread, right? So being able to evaluate more on those specific symptoms, especially when we have physical and psychiatric conditions that do share a lot of similar things like sleep
Mm-hmm.
and appetite and, those kind of things. So,
For sure. Another question here, I think this one is more for Chantal. Chantal,
Okay.
are there specific palliative care nurses at Waypoint, or do all nurses receive some sort of training?
It's like you're looking at the palliative nurse. It's me. No,
me.
so actually, all nurses are receiving training. So I do a lot of education. Julie also graciously does come in as well to provide education. And as of next month, we're developing palliative champions who will be able to, kind of train the trainers. So they're starting on their fundamentals in palliative care October 15th, I believe, this next intake. And we've had quite a responsive feedback. And I've also developed a palliative e-learn that goes out to any patient-facing staff, so not just nurses. So that's our social workers, recreation therapy, occupational therapy, all of that as well, and meeting with the doctors a lot to encourage them to use the order set that was created for them.
Oh, that's
So
great.
long answer, no. Or short answer, no. It's just
And then vice versa, a lot of palliative care nurses do not have that extra training in dealing with patients with SMI. So I'm trying
Mm-hmm.
to change that as well in the other homes that I support, like long-term care.
Right. Now, another question here. We just have a couple more to go. What resources are available for long-term care to build their capacity to work with people with SMI and rebound psychosis?
So
yeah.
it
So
it kind of varies, right? Like from area to area. We have the geriatric services, the geriatric mental health out of Waypoint,
and BSO.
NBSO, Behavior Support Ontario. So
Mhm.
it really depends on your region, what is available, what even province or country you're in as well, right? So we have a virtual binder. If you check out our website, that has some information in there as well, or feel free to reach out to myself and I can certainly lead you in the right direction.
Yeah, and
But
if you're just
there's,
speaking
so sorry, go ahead, Chantal.
I was like, if you're just speaking about your home in particular, within the resources, we've pulled where we got the information around rebound psychosis, and perhaps it's also a matter of just shining a spotlight on it. It's not a term that people think about too often or experience too often for that matter, right? Or they might be thinking this is just how this person presents, but it's actually the rebound psychosis. So it's very often not seen kind of right away. I will say that person does stabilize to their new normal after a few days. But when you get the slides, feel free to look at all the references as well.
Mhm.
And then in patients with alcohol use disorder or anti-relapse meds on anti-relapse meds, do they require a different approach to pain management? And is it ethical to take them off their meds that reduce cravings?
So we have patients, Mr. Bagans being one of them, that have that. However, a lot of those medications that reduce cravings are oral. So we try not to keep them on as long as possible before we then have to go over to our sub-Q or IM routes. We tend to use sub-Q more often than IM, just given that that is what's occurring. And we also have the benefit of having addictions counselors at our facility. So we'll also put in a referral for them so they can be more supported with non-pharmacological interventions if they're at that point. Whether or not it's ethical, I think that's a difficult, question to answer. If the patient is, PPS of 10 and can't swallow, I mean, that
Mm-hmm.
seems to me like, well, this is what we can do to make you comfortable. As far as pain goes, I try to always, teach staff that the pain is whatever the patient's saying the pain is. I, like I'm not in their body, I can't determine that. And it will depend on the pain scale that we use would depend on the cognitive ability and the presentation of that patient.
Mm-hmm.
So we do use the regular scale of 0 to 10 for folks that are, cognitively intact and are able to have that conversation with us. Absolutely. Like Julie was saying, we use the pain AD for our folks with dementia. I will say for our folks with dual diagnosis, there's no actual pain scale made for that population. So that's a significant gap in palliative care at the moment.
Mhm.
We'll have to get on that.
Mm-hmm.
Figure something out.
So yeah, when their PPS is 10, 20% and they're oral, they can't swallow the pills,
Mm-hmm.
you know what, we're going to treat more of the symptom, right?
Mm-hmm.
So if we have to use some sedatives or some anti-anxiety, like any of the PAMs to treat, to treat any of those restlessness, delirium, anything like that, then that's kind of the goal at that point. But, 30% where they're still eating it up, yeah, we're going to try and leave them on their medications for as long as possible.
Yeah, so we wouldn't necessarily do a different approach to pain management at that point.
Yeah.
Wonderful. Great questions today and fantastic presentation. Thank you so much, Julie and Chantal.
Thanks for having us.
For everyone still on the call, please be sure to fill out the satisfaction survey. Let us know your thoughts about today's presentation and check out the website for our upcoming presentation, as well as keep an eye on your inbox. You've got some goodies coming your way.